अस्सलामुअलैकुम एवरीवन। उम्मीद है आप सब लोग खैरियत से होंगे। आज हम जिस टॉपिक को डिस्कस करने जा रहे हैं वो है प्लास्टिक एनीमिया। अच्छा, प्लास्टिक एनीमिया में क्या होता है? आपके पास पैनसाइटोपेनिया। इट मीन्स कि आपके पास आरबीसी, डब्ल्यूबीसी और प्लेटलेट्स ये तीनों कम हो जाते हैं। सो वी कॉल्ड इट प्लास्टिक एनीमिया। एक दूसरी कंडीशन होती है जिसे कहते हैं प्लास्टिक क्राइसिस। यू शुड नॉट कंफ्यूज इट विद प्लास्टिक एनीमिया। इसमें सिर्फ आपकी जो आरबीसी आरबीसी काउंट होता है वो कम हो जाता है। तो जस्ट एरिथ्रोपोइसिस इज टेम्पररी सप्रेस्ड और इसका काज है पार्वो वायरस B19 इन्फेक्शन, जिसे एरेथीमा इन्फेक्शियोसम या फिफ्थ डिजीज़ भी कहते हैं। अच्छा, अब अगर हम एटियोलॉजी पे आ जाएं तो प्लास्टिक एनीमिया के काजेज़ क्या क्या हैं? यूजुअली एडियोपैथिक होता है, इम्यून मेडिएटेड। ग्रेटर देन 50% ऑफ द केसेस में द काज इज़ अननोन। फिर इसमें आ जाती हैं मेडिकेशंस। मेडिकेशन में कार्बामेज़ेपिन, मेथिमाजोल, इंसेड्स, क्लोराम्फेनिकोल, प्रोपाइलथायोरासिल, सल्फर ड्रग्स, cytostatic drugs like alkylating agents and antimetabolites. Then we have toxins like benzene and toluene. We have ionizing radiation and viruses like HBV, EBV, CMV and HIV. So these all are the causes of aplastic anemia. Now we should learn about Fanconi anemia. This is hereditary and autosomal recessive disorder due to DNA cross-link repair defect resulting in bone marrow failure. What will be the finding? इसमें क्या होता है? skeletal and organ abnormalities होती हैं, short stature, hypo and hyperpigmentations. Then we have cafe outlet spots, microcephaly, developmental delay, and thumb and forearm abnormalities, kidney, GI, heart, eye, and ear abnormalities. So you should learn these points to differentiate it and to diagnose the Fanconi anemia. So what will be the finding? Short stature, hypo and hyperpigmentation, cafe outlet spots, microcephaly, developmental delay, and thumb and forearm abnormalities. What will be the lab test show? It will show pancytopenia and normocytic or macrocytic anemia. As we have discussed, that anemia resulting from bone marrow failures can be present as normocytic, microcytic or macrocytic, but usually it present as normocytic anemia. 50% of patients with Fanconi anemia will develop AML, acute myeloid leukemia or myelodysplastic syndromes. Okay, now we will discuss the clinical features of the aplastic anemia. So it will present with fatigue, malaise, pallor, purpura, petechiae, mucosal bleeding and infection. These are all as a result of decrease in RBC. As a result of decrease in RBC, the patient will feel fatigue and will present with pallor. Due to decrease in platelets, there will be purpura, petechiae and mucosal bleeding, and due to decrease in WBC, there will be infections. Now, how to diagnose and how will you identify from the lab finding that this is aplastic anemia? First of all, you should do CBC. So in CBC, you will find pancytopenia and other finding there will be normocytic or macrocytic anemia. In contrast to aplastic crisis is characterized by anemia only. And further checking the retic count, you will find low retic count and EPO will be high. So these will give you the clue to diagnose the aplastic anemia. You will have pancytopenia, you will have low retic count, and you will have high EPO level. When you have low EPO level, so it gives clues about chronic kidney disease. On bone marrow biopsy, you will find dry bone marrow tape, which is hypocellular fat-filled marrow, and RBC morphology will be normal. So these are the findings which are very important to diagnose the aplastic anemia. Now, if we discuss the treatment, so in the treatment, first of all, causative agent should be removed or stopped. And then we give supportive therapy. In supportive therapy, we treat the infections, we give RBC transfusion, and we give platelet transfusions. And then we can give bone marrow stimulants like granulocyte, monocyte colony stimulating factors, and altrombo-PEG. Immunosuppressive therapy, we give cyclosporine, antithymocyte globulin, tacrolimus, and almetosomab. Immunosuppressive therapy help to prevent further destruction of the marrow. And in young patient, we can consider hematopoietic stem cell transplantation as well. Okay, now the agents that can cause aplastic anemia, the drugs you can remember by mnemonic can't make new blood cell properly, can't carbamazepine make methimazole, new NSAIDs, blood benzene, cells chloramphenicol, and properly propyl thiouracil. Okay, whenever you find in a case that there is pancytopenia, so you should have to keep in mind that pancytopenia can occur either in ALL, acute lymphocytic leukemia, or aplastic anemia. To differentiate them, we do bone marrow biopsy. In ALL, you will find blast cells, while in aplastic anemia, there will be a reduction in all hematopoietic tissue replaced by fat species. So that's all about aplastic anemia. If you have any question or queries, so you can ask in the comment section. Thank you everyone.